Welcome to the third virtual roundtable in our series. Today's topic is going to be exploring birth defect surveillance programs and evaluating referrals to services. My name is Justin, and I'm a program analyst with AMCHP's Clinical and Community Collaborations team. And I'm joined by my colleagues, Sabra Ankner and Dr. Cheryl Clark, who will be providing the presentation for today's session. Just want to make sure that everyone can hear me. Okay. I'll take the silence. Okay, I see a thumbs up. Thanks. Just a quick overview for today. I'll introduce Cheryl shortly, Dr. Clark shortly, and then she'll take over and provide about a 30-minute-ish presentation, and then we'll open up for some questions, peer sharing, thoughts. We are still going to offer a Jamboard response option that we'll share the link to later on, and I believe near the end, we'll also launch a short evaluation poll within Zoom to collect additional feedback and thoughts on the session today. Of course, we always want to acknowledge and thank our CDC partners for supporting this series and the broader work that continues around this space. So moving on, welcome, Dr. Clark. I'll stop sharing our slides and you can begin your presentation, okay? Where is the... Okay, thanks.
Cheryl, you're muted and we are seeing your slides, but not in presentation mode.
Right. I just wanted to make sure you can see things before I got things ready. Thank you, Sabra. Hello, everyone. Good morning, good afternoon. I know we're in different time zones, wherever your time zone may be. I hope your day is going well. I just want to give people forewarning that we were supposed to get a thunderstorm storms yesterday, but looks like that's happening today. So if I blip out on you, please know that I'm okay. Maybe you'll have some time back in your day, or maybe Sabra and Justin will improvise things. I probably should have sent you folks a PDF of the slides, but I think we're good to go. As Justin said, you know, I will be hopefully just highlighting some things that I'm seeing. I'm not the expert in referrals to services, or nor, you know, do I currently work in birth defect surveillance, but I think we can kind of just have some ideations about some things, see some examples of what's out there. And I think this is pretty informal, is it not, Sabra? So if you have questions, just throw your icon hand up or signal to Justin. I'm not going to be able to see everyone, so they'll have to be the folks that kind of signal me that there's questions. So first, I'm a data person and epidemiologist for many years. I always find that I need to do some self-affirmations about my importance to the society. And I think that we suffer, and I'm going to include all you, maybe I'm projecting my feelings onto you, that sometimes we feel like we're taken for granted. All we do is get data, and people always ask for stuff and really not really vary what they want, but we can provide more if they would just ask, et cetera, et cetera. So first, some affirmations on the importance of you and what you do. If you are an active participant of a birth defect surveillance program, or you are an active supporter of a birth defects surveillance program, it is proven to be very, very vital and necessary. Aside from of course, the obvious, which is data collection and analysis, and also working to improve data, working to disseminate that data and products, but also information that it provides. And also, you know, we can't forget about the subjects of this data that are often participants in Title V programs across our country. And then also the education and advocacy that some of you folks provide directly or facilitate others to provide, and also the advocacy and assistance to families. So we're going to talk about one of those things that, you know, some of you do, and I guess some of folks are interested in doing, or just kind of curious about how other people do the referrals to services and intervention services. So I had Sabra ask me what, first, any evaluation or any kind of onset of anything we want to know, well, what do people expect us to do? So our friends at the CDC sent Sabra some excerpts from the state cooperative agreement. And then I note, and they highlighted that there's expected evaluations for 2 of 3 categories. The first being surveillance, the second being the always important improvement of data quality, but that third being improving primary and secondary prevention. And kind of a subset within that is the effectiveness of any referral process, and then also methods to improve prospective tracking of children with birth defects. So I got to move people from, I'm going to be able just to see only me. So some of the success indicators that were in these excerpts were that data is shown to identify high-risk populations and also the prevention strategies that are associated with those high-risk populations, and then also if there's a plan to refer folks to healthcare services or social services. And then of course the CDC wants to see that so they could probably implement it in other models or highlight it as an example. And then what are, how you facilitate and get through barriers of tracking children through time after identification of whatever condition that they may have or status. So there's an expectation that something will be evaluated, and you can do the tried and true, which are our norms, which are surveillance and then data quality, or you can venture out into this new fold, newest for some, maybe not for all, of referrals. So last year, AMCHP was involved, and we worked with my team particularly, worked with Sabra's team, Sabra and Justin, to do what we call an environmental scan of collaboration between birth defect surveillance programs and Title V programs. And we just did some descriptors of kind of the norm functions and activities that were conducted by the birth defect surveillance programs that responded to our survey. We didn't get all of them. We got about 30, which is a good chunk, I feel. But we were, the proportion of folks that programs that were doing prevention, referrals to prevention and intervention services was a little bit less than a little bit, kind of half-ish, but not as high as proportion as folks that were doing, of course, the surveillance and things related to data. So, and then I was just looking on the internet back in the day, some older documents that were produced, I think, by the prevention network that maybe a lot of you belong to, that found that there were very few at that time. That was like 2003. So it's grown a little bit, and so that's good. And so, but still, like I said, less of a function than some of the other functions that are kind of traditional with surveillance programs, I feel. So also back in the day, looking back on the internet, I saw that there was a presentation that was provided by folks at the CDC, and this was in 2009, and the authors are cited below of that presentation, but they kind of have a conceptual model of what birth defect surveillance do within the cooperative agreement that was being implemented at that time. It's kind of smallish on your screen, so of course, I love smart art in PowerPoint, so I blew it up so you can look at the pretty colors, and also highlight the main components of that cooperative agreement, which are, as you know, surveillance, capacity development, prevention and referral, and then evaluation. And then all this is supposed to result in, kind of great birth defects surveillance methodology, and the ability to transfer information, ability to provide outreach, and also, related to the referral piece, coordination and intervention channels that link children and family to services. And this all will lead to hopefully improved health outcomes for all that are involved. So focusing on that, just the prevention and referral piece, just highlighting that in this second graphic that's derived from that cooperative agreement presentation about evaluation. So what we can do is, of course, we have we have our lovely central public health services that's now revised and has equity at the center of it, and listing it out. The underlying things that you see are kind of the ads, in my opinion, compared to the prior agreement that focuses a lot on equity. And so the bolded lines you will see there: ensure access to services. And the important thing is to ensure not only access to services, an effective system that enables equitable access to individual service and care needed to be healthy. And then, of course, there's they cram all that together with evaluation, research, and quality improvement, that everyone should continue to improve and innovate all of our public health functions through ongoing evaluation, research, and continuous quality improvement. And I would say that also, you can't see my cursor, maybe you can, that inform and educate, because as we are providing services, folks should be trying to figure out how to do it better, and then also learn more things about what they can do as part of these intervention and prevention services. So all aligned with that, we have the great tried and true, I say that a lot, CDC evaluation framework to engage people, describe, focus, gather, justify, that whatever. And me getting older, note that when I first came to AMCHP, there was a wave of quality improvement going on. And people were saying, quality improvement is not evaluation. It's not the same, or rapid quality improvement wasn't. And I was like, yes, it is. It's still the same. It's just one is expected to take place quicker, but it's the same process for anything you want to do. The whole thing is, how can you prove that you are doing what you said you're going to do? And then how do you prove that you're doing it well? How do you prove that you're doing it effectively and it's having some kind of impact? So I'm taking this example that I obtained from another publication that was published in 2016, but they used newborn screening as a platform for this framework. But there are not a lot of documentation, as I'm sure some of you know, about how assessing outcomes, referrals from birth defects surveillance programs. So I'm going to be using a lot of the screening literature to just set examples, but I feel like it's not plug and play, but it's very, very, very similar as what you would do if you want to evaluate the referral services from birth defects for surveillance programs. So they had the measure concepts, which I've said repeatedly now, and how many minutes into this presentation, screening, and then there's also this care consistency and guidelines. And then they had the patient services and clinic care, but that also included access processes, transitioning, like children to adult services. And then there was surveillance, of course. The drivers of all of this are, rapid and I'm snapping my fingers, you can't hear it, rapid and reliable detection and diagnosis, the provision of evidence-based therapeutic and habilitative care, coordination of these holistic spectrum of services, or wraparound services, as some people call them. And then also CQI, which is continuous quality improvement of the mechanisms of care discovery and innovation. And of course, everyone's hoping that all this leads to improved survival and well-being in the form of reduced mortality, maybe mitigation, reduction in major complications, improved functioning, or a optimalization of functions, growth and development, and then also incorporating the patient and the family experiences, and then the mitigation or reduction of disparities. So I find that sometimes, when I'm working to try to assess or evaluate something, I look at the whole picture and it's overwhelming. So to break it down, and they did so on the table form, and I'm doing so in Smart Art because I love graphics, that we can kind of make it kind of linear and kind of maybe more process oriented to kind of get our mental arms around what we need to do. So our primary driver for this example, and this is a newborn screening for that's going to use sickle cell disease as an example. So one of the aims is a rapid, reliable detection and diagnosis. And then the key attribute being that every newborn hopefully gets screened. There's a screening performed, and then there's diagnoses that are springing up from that universal screening. And how do we know? Because the sickle cell disease is detected by this, and then it's also the diagnosis is confirmed via this screening. And the data sources being that your own or respective newborn screening programs, or I think it's still, and if some of these sources are not valid, please forgive me, but the sickle cell data program that's hosted by the CDC. And then you have these specific measures of what you're looking for to assure that there is rapid, reliable detection. And these are the outcomes of how many infants were confirmed diagnosis and then how many were detected at birth. The second example being using sickle cell disease as another, as the example being provision of evidence-based care. And this is the key attribute that there's evidence-based treatment. And then there's two concepts of which are aligned with prevention, and that's prevention of disease-related mortality among children with sickle cell disease, and then also the early initiation of prevention of pneumococcal infections like penicillin, given at different interventions as specified by the literature, the evidence, right? And so how do we find that? Through that we prevented or there's reduction in mortality through our state mortality data, also probably through any kind of program that you are aligned with, the sickle cell program being part of the CDC stuff. And then also, maybe some surveys, and they say HRSA supported surveys. I would think that would be the National Children's Survey. They definitely have measures in there that are tracking all kinds of conditions for children, and that you can also have that national measures and also state-specific measures within that survey. I tried to play with it because I want to know if I can do it. And if I can do it, anyone can do it. So I just use same platform with sickle cell services and interventions, but the coordination and integration, which wasn't in the article or wasn't in that framework, but this is my stab at it kind of. And then, so we have our primary driver being a coordination integration of services, the key attribute being referral to sickle cell disease services, and then the measurement concept being services access. And then also, but that's reflected by patient-centered engagement and satisfaction. Our data sources being a National Children's Survey. Also, this may be collected with the sickle cell data collection program. I'm not really sure, but the measure in the National Children's Survey is the percent that of the respondents with difficulty receiving services among those sickle cell children who needed them. And that is a primary marker component of a medical home measure. So I searched the globe, the internet globe, for some more kind of just examples, and then we can start a discussion about what you do in your states or jurisdiction. This was an example, and I didn't find a lot from the United States. The United States is not very good at publishing evaluations of public health programs. And also, like I said before, particularly with birth defect surveillance programs, I couldn't really find much of anything out there. As far as evaluation goes, it was more about what we're doing in our states, but not about the evaluations of those things. So this is an article that did a systematic review of 5 databases, and they were really trying to do newborn screening. I know, like I said, it could be something apples and oranges for folks like in your relative jurisdictions, but like I said, these are just examples of processes of evaluations that are out there that I know that can be modified to fit your needs in different components of evaluation that you want to do. But they wanted to examine kind of between like, what was the referral rate loss or loss of follow-up that was maybe influenced by different factors, and they want to know what those determinants were, so they can, you know, just identify them and maybe folks can kind of start dealing with them. So this diagram is just like a timeline, you know. So if the family, if there's some issues with the first screen and they ask the family to come back and have the infant have another second hearing screening. So they wanted to basically examine the screening method and then other modifiable and accounted for determinants for the effect on referral rates from step 1. And then they wanted to also determine whether infants who had a higher risk for permanent hearing impairment, if they also have a higher risk for being lost to follow-up after screening. So what they found out, and that, you know, it was kind of a hard article to dig this stuff out of, and there was really a lot of complex interactions, but basically this is some of the things I pulled out of it, that the screening method, you know, did matter. Also hospital size mattered. And then also if the screening was done by a tech versus a nurse or a volunteer, that sometimes they had a lower loss to follow up, but that was moderated by if there was a presence of an audiologist. And then also infant, you know, on an individual level, if the infant was quiet and sleeping, there was a lower referral rate rather than, I guess, the awake infant. NICU status was also implicated in inpatient versus outpatient. And then also the age of the infant since birth, because there was, if for each increase in age, they had a lower referral rate. So some of those things can be kind of examined in an evaluation. It may not have to always be the outcome, it could be the process. I love graphics. This is really confusing, but like I want to show it anyway. This was a kind of a global, you know, it's not the best graphic to present to communities, but I just wanted to show that folks, you know, have, you know, mapped outcomes by referral status, just to see, you know, maybe if there's impact on, is there a difference between folks, I mean, infants that were referred and not referred? Was there like higher mortality rate, or maybe difference in location of, you know, unfortunately, these children, infants died when less than 7 days from birth, but, you know, would have been impacted if they had been referred to appropriate services or facilities. So they just kind of broke it out that way. This is another process evaluation, but it's more on a communication intervention that a lot of this, like I said, a lot of these things are in more detail were done over in England or Europe. Unfortunately, the United States, like I said, doesn't tend to publish a lot of things that are really useful, and we should start doing that more. Or maybe published to websites and not available to, you know, in peer-reviewed or open access journals. But anyway, these folks wanted to assess whether the communication interventions that they had designed, and they kept making emphasis on co-design, were being effective, and where they were, you know, were they improving, you know, communications for newborn positive screening results. So they did an audit of form completion, you know, where they asked the staff to send in those forms, and they were, you know, they were assessing them to see if they were completed for accuracy and if they were complete totally at all. And they also did some semi-structured interviews with health providers on views of the forms, and then also with parents who received a positive newborn screening with or with, you know, without the communication interventions, to view their, you know, to get their assessment on their experiences and perceptions of the communication. So what they showed was there was a wide variation in communications and like how people were completing them, but that was mainly attributed to these organizations and kind of contextual barriers. So they figured that they need to work on that to clarify the processes for providers a little bit better. But all in all, the providers had positive feedback about the purpose of the intervention, and then they had they were okay with the completion of the form. Maybe it was just the way the system presented the form, I'm not sure. But the parents, and this is so important before, you know, they were really kind of happy with the consistency in pacing and tailoring the information, as well as being able to provide information. I'm not sure, you know, I saw one example, but I'm not sure how involved folks programs are with, you know, our client, you know, contact, if that's forwarded off to another entity to do that. But you know, that's just, I think, so important to not only, you know, evaluate our data and make sure our data is good, but how's that data being translated and how's that being communicated back to people who really are the subjects of that data and then can use that to make their own healthcare decisions. So one of the things that I find that is very, very kind of overlooked, particularly with evaluators, is evaluating collaborations and partnerships. You know, it's going to bring up that term that people get confused about, that qualitative data or qualitative assessment is not as important as quantitative. And let me tell you, it is. And we can learn a lot from our friends in social services, folks who are, their business is to interact with people and communities. And then this phrase, that authentically connected, is when you have an integrated network with agencies functions as equal players with each other and with the client to identify and address the complex interplay of needs. And one of the things that I've seen, you know, some of the children's survey data I've looked at is that parents are frustrated sometimes and they don't feel like their providers or the people informing providers are connected to them or each other. So the biggest benefit, you know, of collaboration is improved health, and that folks should just keep that in mind. And then that means everyone in the line of, you know, I do a whole nother presentation about data, you know, equity in data in a data life cycle. And part of that life cycle is communication and translation of data. And that means, you know, that folks feel included and there's equity in translation, and people kind of, everyone in the process is involved, including us data heads are at the table as well. There are some collaboration evaluation tools that are out there for free. We love the Wilder collaboration factor inventory. You can modify it to best fit your needs, not change it, but maybe not use all the questions. There's also, you know, these couple other examples that I haven't really used a lot, but they're out there. And so I would advise, if you know, if you are doing any kind of evaluation, that you also consider evaluation how people work with each other, and if their collaborations are effective, or just circling and just having a bunch of meetings without any progress. So I think I am at 3:30, and so I want to open it up. And I know that Sabra has a mechanism for y'all to put your thoughts into. I do have a couple of questions to start us off with. And so I guess we can stop recording now, Sabra, and then we can get to the